All right. So we've talked a lot about ventilation and kind of anatomy and physiology this semester. Now I just want to kind of discuss with you guys how our brains control that ventilation. So breathing is actually kind of a complex process. It's going to rely on a lot of coordination of those respiratory muscles. And there's different control centers within our brain that will control different aspects of kind of the rhythm and the rate and the depth of our um, inspiration and expiration. Okay. So, in this chapter, we're going to kind of discuss those different centers and the different types of factors that are in influence or stimulate those centers to regulate respiration, ventilation. So just kind of a couple objectives for you here. Right. So interestingly, most of the control centers for breathing are controlled um, in your brain stem. So that's why a lot of times with patients, even that have pretty severe head injuries, unless there's brainstem involvement, the patient still is going to have that involuntary control of breathing functioning. So the medulla respiratory centers are kind of the main centers within your brain. Um, uh, Interestingly to note, we also don't have a complete knowledge of how everything works together, but we know that there are collective neurons inside that medullary respiratory center that are going to be responsible for controlling inspiration and expiration. So these two centers are considered the dorsal respiratory group and the ventral respiratory group. Okay, and they're located down here in this medulla oblongata. Above the medulla oblongata, this is where your pons is located, and this has a pontine respiratory center and an apneustic center. These also have some specialized function with ventilation. So, talking a little bit more about the ventral respiratory groups, these groups are thought to be responsible for um, inspiratory muscle contractions and so this is going to be kind of in control of the triggering of inspiration. But they also work to coordinate rate, depth, and rhythm of breathing. This is also where your gasping breaths. So we're going to talk a lot about gasping breaths. You've probably heard about that when you took your CPR classes. Talk more about it when you take ACLS, but this is kind of your body's last ditch effort to breathe during periods of like severe hypoxia. Your dorsal respiratory groups are located also in the medulla oblongata. These kind of again are those primary inspiratory centers. I think now it's understood better that the ventral group has more control over inspiration, but these do get stimulated by like our peripheral stretch receptors that we're going to be talking about later on, and our chemoreceptors. And then they relay that information to the ventral respiratory group to trigger inspiration. Okay, the Pontine Center has your Pontine respiratory group and your apneustic center. Okay, so the function of this is kind of to fine tune the rhythmicality of your breathing. Okay, so it works together with those ventral respiratory groups. When your pontine center is injured, or especially that apneustic center is injured, you can have an irregular respiratory pattern called apneustic breathing. I couldn't find a very good video about apneustic breathing, but it's described as a kind of this breath holding phenomenon where the patient breathes in deeply. So you'll have that gasping inspiration, but then they kind of hold their breath at peak inspiration, and then they have just a incomplete or quick exhalation. So that'll be this big, deep inspiration. The apneustic center, which controls how long you inspire for, it never shuts off that inspiration. So the body's told, hey, we need to take a breath in. But because there's a disruption in the center that controls when we stop breathing in, we kind of continue to breathe in. We have this weird, awkward breath hold at the end of inspiration. And then there's this like incomplete exhalation. Okay. So normally this apneustic center is going to respond to different inhibitory signals, specifically the Heringer or Brewer reflex, which is a kind of a hyperinflation reflex or sensor in our lungs. So as our lungs expand, it's going to trigger this Heringer-Brewer reflex that tells us, hey, our lungs are getting too full. You better stop breathing in, and allows for expiration. Okay. So significantly, and we talked about this in airway management, when you have injuries to your spinal column, that's going to have a profound effect on your patient's ability to move and breathe. So you have that phrenic nerve that emerges at C3 to C5. Any injury to this can cause a complete or incomplete diaphragm paralysis. So that's very significant when you have injuries to that cervical spine. So there are several factors that are going to influence the rate and the depth of breathing. The major known areas are what we call your chemoreceptors and your either central or peripheral chemoreceptors. So your central chemoreceptors are actually the most powerful stimulants known to influence that medullary respiratory center. And these central chemoreceptors respond to concentrations of hydrogen ions in the cerebral spinal fluid. So you have those central chemoreceptors that are located in the medulla, and they monitor those hydrogen ion concentrations in that cerebral spinal fluid. Okay, so as CO2 levels increase in the arterial blood, so as your PaCO2 increases, these CO2 molecules are going to diffuse across this blood-brain barrier. Okay. And then there's going to be kind of a reaction that occurs, which you don't have to know the chemistry of all of this, but it forms carbonic acid and also forms free hydrogen ions. Okay, these liberated hydrogen ions cause those central chemoreceptors to transmit signals then for increased ventilation. So that makes sense, right? As you've learned about acid-base balance, you know that our body wants to keep our PaCO2 between 35 and 45, right? So as our CO2 climbs above 45, our body has these built-in mechanisms to sense that. And when it senses that elevated level of CO2, which produces these free hydrogen ions, it's going to trigger these chemoreceptors in the central medullary complexes to send a signal to the lungs to start either increasing the rate, so increasing respiratory rate, or increasing your tidal volume, your depth of breathing. Okay, or both. Okay, so your peripheral chemoreceptors are located kind of high in the neck and in the carotid arteries in the aortic arch. So that's where those are kind of located. And these are going to be impacted by low PaO2. So in patients that when they sense those low PaO2 levels, so anything less than, so these are respond to PaO2s less than 60. So I did that backwards. So less than 60, the peripheral chemoreceptors will be stimulated. When they get stimulated again, they are going to want to increase the respiratory rate and depth of breathing. Okay. So as your PaO2 drops significantly low, so if it's severely low, below like a PaO2 of 30, this then becomes kind of suppressed. So it only functions within a kind of a range between 30 to 60 for your PaO2. So in patients like that have chronically low PaO2 levels, like your COPDers, these peripheral chemoreceptors may kind of take more control over ventilation because that chronically high CO2 level is going to inactivate the sensitivity of those central chemoreceptors. So your peripheral chemoreceptors are going to play a bigger role, or in theory, to your COPD patients that are chronically have chronic high CO2 levels. Oops. All right. So there's several other factors that are going to kind of influence the rate and the depth of your breathing. You have your Herring-Brewer reflex. This is also called your inhalation reflex. It's generated by these stretch receptors that are located inside that pleural space of the lungs. So it's going to become stimulated anytime the lungs are overinflated. Okay, so as these lungs become overinflated, it's going to send signals to the medulla to stop inspiration. Okay, so this is just going to control ventilation and protect the lungs from damage from that excessive amount of lung inflation. So typically our chest wall in adults is rigid enough to control hyperinflation in our lungs. But in babies, your chest wall is significantly more compliant. So that's kind of a little bit of the theory why that Herring-Brewer effect is more significant in newborns than in adult patient populations. The deflation reflex is kind of works the opposite. So if the lungs are compressed or deflated, it's going to increase your rate of breathing. And that's just because that's going to try to help maintain that same minute ventilation. So if I'm not breathing deep, I need to breathe faster, rapid, shallow breathing. Your irritant reflex, we have this anytime our lungs are exposed to things like noxious gases or any types of irritants. This is going to cause kind of a vagal response that's going to increase your respiratory rate. And it also produces like kind of a reflex for coughing, sneezing, bronchoconstriction. This is actually really interesting when we start talking about smoke inhalation in respiratory disease management in fall semester, because we have several reflexes in our airways to protect our airways from heat and thermal injury. So we'll talk about those kind of a little bit more next semester, but it's kind of fascinating how that all works. You have your juxtapulmonary capillary receptors. These receptors react to certain chemicals, and they are stimulated by, alveolar inflammation, pulmonary capillary congestion and edema, and different like humoral agents. So this reflex also triggers that rapid shallow breathing to try to be protective of the lungs. And your peripheral receptors are located in the muscles, kind of tendons and joints. When these are stimulated, this increases kind of the number of inspiratory signals. This is why, this is kind of thought to be why sometimes our respiratory rate increases during exercise. So as we move our joints and tendons, that initiates that increase in respiratory rate. So the more our joints move, the greater your respiratory rate. We also have hypothalamic controls. These controls are located in the hypothalamus and can kind of alter our respirations. So when we get excited, our respiratory rate increases, just like when our temperature increases, our respiratory rate increases. And the opposite happens like with cold stimulation. So we've all probably jumped in a really cold pool before, and the first thing you kind of feel is you like take that gasp when you feel like you can't breathe. You're like, and you stop breathing for a second. That's from that cold stimulation, and that's kind of an involuntary response from those hypothalamic controls. The cortical controls, this is normally controlled by that involuntarily by that medullary center. This but these cortical controls are like our voluntary responses. So even though our breathing is usually involuntary in that medullary center, our frontal cortex can also consciously tell us to take this is why I can consciously take a deeper breath or consciously make myself breathe faster or slower. And these aortic and carotid sinus baroreceptor reflexes, these are located near those peripheral chemoreceptors in the aorta and the carotid arteries. And they are responsible for increasing heart rate and ventilatory rate in response to blood pressure. So when we talk about hemodynamics in the next lecture, we'll talk a little bit more about blood pressure and cardiac output. But if you think about it, your lungs and your heart are responsible for bringing oxygenated blood to the tissues in our body. So if our blood pressure appears to be low, if these baroreceptors in our aortic and our carotid sinuses, if that senses a low pressure, then the heart is going to trigger our lungs to breathe faster and our heart to increase its rate in order to try to compensate for that lower blood pressure and still perfuse our tissues with enough oxygenated blood. And then the opposite is true. If you sense a high blood pressure, then these baroreceptors are going to try to slow down our heart rate to kind of control perfusion that way. So talked about this a little bit more in depth now is the central chemoreceptors. Those are most powerfully stimulated by the amount of hydrogen ions in that cerebral spinal fluid. So this is the picture from your textbook that has this blood-brain barrier here that shows you how CO2 can cross through that blood-brain barrier, but bicarbonate and hydrogen ions cannot. As CO2 crosses over, it attaches to water molecules, so H2O, and creates carbonic acid, which then is broken down into bicarb and these free hydrogen ions. So the more CO2 that's in our blood here, so our PaCO2, the more that can get diffused across into the cerebral spinal fluid, the more that diffuses across, chemistry happens, and the more free hydrogen ions that are loose in that cerebral spinal fluid. Okay. These chemoreceptors are going to be activated by the level of hydrogen ions that are in this fluid, and that is going to stimulate a change in ventilation. So if I have a lot of hydrogen ions up here, my brain is going to send a signal to my lungs saying, hey, you're not doing your job. You need to breathe faster or deeper to try to get more of this carbon dioxide out of our blood so that it doesn't create these hydrogen ions in our spinal fluid. Okay. All right. So again, your peripheral chemoreceptors are going to be those ones that react to our oxygen levels. So centrals responding to CO2 levels, peripheral chemoreceptors respond to oxygen levels. Okay. So these are usually in those high in the carotid arteries and, or in the aortic arch. Sometimes they're referred to as the carotid bodies. So here where are you guys? Trying to find you. These are your baroreceptors up there. Here are your oxygen carotid bodies right here and here. So those are your peripheral chemoreceptors. And then here's your one in the aorta down here. Okay. So they're close to those baroreceptors, but they're not the same structure. So they're separate from that, and they're also sometimes referred to as those carotid or aortic bodies. So how this happens, this illustration shows how when that low PaO2, because I either am not getting good enough ventilation in, so I'm hypoventilating, I'm not getting oxygen into my body and then into my blood. That unoxygenated blood or that low oxygen content blood then is going to get pumped out of the heart to these and pass through this aorta and these carotid bodies right away. So if you think about it, these are positioned in a good spot to tell me to be able to sense this low oxygen early and then hopefully send these stimulations through these vagus nerves and the glossopharyngeal nerve to that medulla center, and then it's going to trigger an increase in ventilation to try to hope to get more oxygen in the body. Okay, so there's only going to be so as arterial oxygen increases, so as it gets better, so if my PaO2 is anywhere from 60 to 100, I'm not going to see a change in ventilation. But as my O2 drops below 60, you can see this increase in ventilation that the body has. It does that until I get to about 30. And then once my PaO2 is about 30, I kind of have this suppression of this increase for ventilation, and then I'm not going to see any further increases in my ventilation after I drop below 30, which is very severe hypoxemia anyway. Okay. So as your CO2 values increase, the sensitivity of those chemoreceptors for your PaO2 increase as well. So that's just kind of, again, relating it to the fact that in your COPD patients, that high CO2 that those patients always have, that's high CO2 retention that they always have, will make the body rely a little bit more on these peripheral chemoreceptors to regulate ventilation. So although the primary stimulant of those peripheral chemoreceptors is those low PaO2 levels, it is also going to respond to increases in CO2 in the blood. So it actually is kind of, because those free hydrogen ions are what stimulates these chemoreceptors, and they cannot pass through the blood-brain barrier. They come in more direct contact with these peripheral chemoreceptors. So as CO2 increases in the blood, or production of non-CO2 acids like lactic acids increases, you're going to have an increase in those hydrogen ions, decrease in your pH, and that's going to stimulate these chemoreceptors to increase that alveolar and ventilation. So there's a couple other factors that are going to stimulate the peripheral chemoreceptors. This can be like hypoperfusion. So, meaning like stagnant hypoxia, so tissue hypoxia, because we don't have a lot of blood pressure. That's going to stimulate the chemoreceptors to increase ventilation to kind of try to compensate for that. Increases in temperature. Increased nicotine is going to stimulate your chemoreceptors, and then they're going to be stimulated directly by your PaCO2. Okay, so it's going to be kind of that direct stimulation by the PaCO2 is kind of minor and not nearly as great as the stimulation in those central chemoreceptors. But those peripheral chemoreceptors do respond faster to the increased CO2 levels. So it's not going to be as great of a response, but it's going to be a faster response. Some other responses that are activated by those chemoreceptors. So in addition to increasing ventilation, the peripheral chemoreceptors will cause peripheral vasoconstriction. So they increase ventilation, but also increase peripheral vasoconstriction to try to keep that blood or oxygenated blood in kind of the central areas of the body, the core critical areas of the body. It's also going to increase that pulmonary vascular resistance, cause some systemic arterial hypertension. It's going to cause some tachycardia and an increase in left ventricle performance. So all of these things work together to try to improve the blood flow to kind of important tissues in the body, or important organs in the body. So that peripheral vasoconstriction is going to increase my blood pressure systemically. Tachycardia is going to increase my cardiac output. That increase in the left ventricle performance should also increase my cardiac output by increasing my stroke volume. Kind of a negative side effect is that increased pulmonary vascular resistance. We obviously don't want an increase in pulmonary vascular resistance, because then that makes it more difficult for blood to go through the blood, to perfuse into the lungs and pick up that oxygen. But this is kind of one of those negative side effects of where the body's trying to shunt blood away from alveoli that aren't well ventilated. But if the majority of alveoli are not well ventilated, it causes this kind of um, total increase in your pulmonary vascular resistance. Um, so those medulla centers are going to kind of coordinate the signals in those higher regions of the brain to increase or decrease your ventilatory rate. There are some other miscellaneous factors that are going to influence your breathing, like pain. Sudden painful stimulation can cause like reflex apnea. So if I, pinch you really, really hard, you might go and, stop breathing for a second. You also, like we talked about before, that's cold stimulation causes reflex apnea. Stimulation of your larynx or pharynx by any irritating chemicals or tactile stimulation can cause temporary apnea. So this is also called kind of your choking reflex. Helps you prevent aspiration of different foods. And we also can have like different reflexes like that your body talks about with like coughing and sneezing and hiccuping. All of those are kind of different reflexes that our bodies have that are outside of the control of that medullary center. Oops, oh, went too far. So interestingly, this has these peripheral and central chemoreceptors function has an interesting kind of complication with high altitude. So if you think about it and you remember that alveolar oxygen tension calculation that I've made you do a couple times now, you understand that as the barometric pressure drops, that is going to lower the entire partial pressure of the gas mixture. So the amount of oxygen or the partial pressure of oxygen in the alveoli will also drop. And once that drops, the partial pressure of oxygen in the arteries will drop. So as I ascend the mountain, my barometric pressure, I deal with a lower barometric pressure, which is going to cause the partial pressure of oxygen in my alveoli to decrease, and then in my blood to decrease. So once that P little a, my arterial blood, decreases below 60, that's going to stimulate those peripheral chemoreceptors. Those peripheral chemoreceptors are going to tell me to breathe faster. But as I breathe faster to try to, increase my PaO2 level, that is going to drop my CO2 level. Because remember, the number one cause of respiratory alkalosis, which is a decrease in my CO2, is hypoxemia, which is my PaO2 being less than 60. So this hyperventilation that this low O2 is causing is going to cause this hyperventilation. So I'm going to continue in that fast or hyperventilated state the entire time I'm climbing up this mountain because of the stimulation of the peripheral chemoreceptors. But even more interesting, as I climb and I'm stimulating those peripheral chemoreceptors, and I'm decreasing the CO2, my central chemoreceptors become readjusted to a new normal level. So they start getting used to the fact that my CO2 level is lower than 35. Okay, so then they feel like this is my new standard to judge everything or base everything off of. So now they're going to become stimulated at a lower rate than before. So as these individuals descend, their respiratory rate still does remain high because as they descend, even though their oxygenation gets better and I'm not stimulating these peripheral chemoreceptors, my central chemoreceptors now get stimulated because I'm I have a higher CO2 level. So it kind of works. This is how our bodies kind of work against ourselves when we're in climates that aren't normal. So like a high altitude. All right. Okay, so that kind of concludes everything for this lecture. It was kind of a quicker lecture, shorter chapter, sandwiched in between some heavy content. So you do have a worksheet that you have to fill out for me for this content that is going to be due on this following Sunday, as well as the Mind Tap activities.